Good afternoon, everybody. I'm Anna Plotkin, Director of Continuous Professional Development at the University of Toronto, and welcome to the Genitourinary Pathology Community of Interest. Just a couple of housekeeping items. Please mute yourself when you're entering the session. If you have any questions, please post them in the chat. If you want to ask your question, please raise your hand and you'll be given the opportunity to ask your question. All the session is recorded and they are posted on the CPD website of the Laboratory Medicine and Pathobiology Department of the University of Toronto. So you can watch them in about 3 to 5 days after the session, and it's free of charge. At the end of the session, please fill out the evaluation form, especially if you're interested to receive a CME certificate, which will be sent to you in about 2 weeks after the event. And you don't need to ask for it if you fill out the evaluation form. Today's session is moderated by Dr. Rola Saleeb, who is the assistant professor at the University of Toronto. And I'm really thrilled to say this is a tribute to an amazing pathologist who worked for so many years and whom I personally know for over 20 years. And it's Dr. Theo van der Kwast. And not only amazing pathologist, he's an amazing person. Very kind, very open, always helpful. And I can always count on him on any occasion I ever asked him. Just to give you a little bio about Dr. van der Kwast, he's an active staff pathologist at the University Health Network since 2006. He's a full professor at the Department of Laboratory Medicine and Pathobiology at the Faculty of Medicine, University of Toronto since 2004. He was a full professor of pathology at the Erasmus Medical Center in Rotterdam, Netherlands. And you can see that sort of European influence in this amazing person. His main research interests are early detection of the prostate cancer, biomarkers development for bladder and prostate cancer, and correlation of prostate pathology with imaging. So he has amazing accomplishment through his career, and he published extensively. But I think he also can say he has so many followers of that were fortunate to work with him, and he collaborated with so many people around the globe. And he's absolutely an amazing teacher. And I was one of his trainees, and I can definitely say I still remember a lot of things that you taught me, Dr. van der Kwast. So really, thank you for this amazing career, and thank you for being with us, and thank you for your support. So Rola, the podium is yours.
Thank you, Anna. I'm very happy that Dr. van der Kwast has agreed today to be our guest speaker. So we'll start by Dr. van der Kwast's case, and then a few of us pathologists will present some cases, and then interspersed in the middle will be 2 more cases for Dr. van der Kwast. So Dr. van der Kwast, please start. Thank you.
Okay, I will start. I will start with share screen. Oh, share. Oh. Yeah, there you are. I suppose you can all see my image. And I will start with this first case. This first case, it's a bit a complicated case, of course. It's a rather youngish male, and he has a history of idiopathic thrombocytic purpura, and he got prednisone treatment for that. He suffered from renal failure, and there was a previous diagnosis at the time we got his first transurethral resection from this patient. He had the previous diagnosis of nephrogenic adenoma, and now he has hematuria. Cystoscopy was performed in our institution, and the urologist told me he had never seen such a bladder before. It looked very, very abnormal, highly abnormal. And we got a transurethral resection bladder specimen, And you can see from this first image already that there is quite a variation in pathologies or lesional tissue. There is glandular tissue and there is squamous tissue, and it all looks different and variable. And I think in a rather systematic way, we will go through this case. And at some points of time, I will ask the audience what they think, basically whether it's malignant or benign. And so this is a first image of a glandular area. So I call this slide glandular areas. And you can see on the left, you can see still the antecedent urothelial lining. And on the right, you see clearly a glandular differentiation. And if you look very careful, you see even at the pits, at the bottom of these glands, you see even the Paneth cells. So yeah, this looks a bit like intestinal tissue, I would say. And here another image of that same kind of region where you see all these glands and with nice intestinal differentiation. And that is typical in a bladder. That can happen. Bladder urothelium can undergo metaplasia, as you know, in all kinds of directions. And so this was one of the images, one of the pictures we saw in this case, quite florid, quite extensive. So we do here a poll, just as a bit of test poll, see if we can do a poll here. Would you call this benign or malignant? Is this malignant, yes or no? And I suppose, yeah, I give everyone the time. Yeah, I think we are pretty good there. I have no idea how many people we have here, but quite a lot. And I think we can, I stop the sharing of the poll. We see that 90% of the people think it is benign. And should I share results? Yeah. Oh, and stop share. You see it all, boom. Well, I think this was a bit a test question. I do not want to offend anyone, but this is a clear example of intestinal metaplasia. And so we would not consider this as malignant. And of course, there can be atypia, more atypia in this kind of areas. But generally, if it starts looking a bit awkward, I go to a GI pathologist and I ask them actually what they think of it, because sometimes you can have villus adenomas or kind of things which are more dysplastic, but this is definitely benign. So we move on. This is another area, and I'm not even going to ask you whether this is benign or malignant, because there were also large areas of this cystitis cystica glandularis. So that was quite obvious and also quite florid. And that explains that explains also a bit why the urologist had this funny image in the cystoscopy. Here we have another glandular area. This slide I call glandular area number 3, because this looks very different. And please disregard the squamous epithelium at the bottom. We will talk about that later. But just look at the glands. These glands, it's very tubular actually, and it spreads all over the place. It's quite extensive, I would say. And here a higher magnification of these same glands. And here I would ask again the poll, if you see this, would you call this benign or malignant? Well, we are close to 50-50 about, I think. 58%, more people can still, there are 51 participants. So people, I cannot see who answered what. So I cannot take it personal. Don't worry, you can put in. Okay, we stop here. So I share the results. We have 43% says yes, it is malignant, and 57% says no, it's benign. Well, the differential of this is, of course, I stop sharing this. Whoop. And got out of it, boom. The differential of this lesion would be an adenocarcinoma, maybe, a bladder adenocarcinoma. It could be a clear cell adenocarcinoma. That's probably what most people have in mind. And another possibility is a nephrogenic adenoma. And actually, the patient was diagnosed previously with nephrogenic adenoma. We looked a bit further. I, of course, don't show everything clearly. Benign or malignant, there we go. And here, this is actually betraying the diagnosis. Here we see a classical area of nephrogenic adenoma, where we see small glands with hobnailing, There's kind of hobnailing, and this is more classical, I would say. And we diagnose this as a florid type of nephrogenic adenoma. However, why is this not a clear cell adenocarcinoma? Because actually the nuclei look quite worrisome. They looked quite previous. They look quite vesicular and they're pretty large, and you should be careful, of course. Well, first thing is, this is a male patient, and clear cell adenocarcinoma may occur in male patients, but it is very rare. And a clear cell adenocarcinoma is much more common in female patients. So that is a bit of statistical consideration. The argument against adenocarcinoma, the main argument adenocarcinoma was that we did not see it infiltrating into muscle or whatsoever, but you could not see that. And particularly, we did not see any mitotic figures in the specimen. So we decided to call this nephrogenic adenoma. So we go further, because these are the glandular areas. And here now we see an area where there are also there is something peculiar happening in the squamous epithelium. There is squamous epithelium, which is kind of metaplastic, I would say, because in females you may have in the trigone, of course, a little bit of squamous metaplasia, but in this male patient there was quite a lot of squamous epithelium, and it looks really odd. What you can see also clearly is that the glandular areas are interspersed with the overlying squamous epithelium. But we never considered the diagnosis of adenosquamous carcinoma or something like that. I don't know what people would think of that, but let's turn our eyes now to the squamous epithelium, because that was the main thing in this case. Here we see the squamous epithelium again. We see really dyskeratotic cells and all kinds of weird nuclear features. The nuclei are very strange nuclei here. And the epithelium looks very disorganized, I would say. And there were occasionally a mitotic figure, but it remains confined to the surface. It does not show any infiltration in this spot, at least, although there are some little nests here, and here maybe two, which seem to be in the stroma. Here another area, and when you see this, people might already think, now I know what this is. Anyone dares to say something to me? What we see is the epithelium is quite broad, but we see vacuolization around nuclei. I would almost say the word coilocytosis, and again, these nuclear changes. Any suggestion? Anyone has something? Is there some, there are some chat messages here. Okay, then if there's no reply, I try to make it a bit interactive, but then I continue, of course, And here we see a little bit more, I would say, worrisome areas. Here we see that the nuclei are quite enlarged, very hyperchromatic. And here are some nests. And here is a larger nest. And here we start our poll again. What is your diagnosis? Benign or malignant? I will help you, but not really. But the original diagnosis from the submitting hospital called this patient having carcinoma. On the other hand, we had some reluctance in calling carcinoma because when the surgeon, the name of the surgeon, he has a particular nickname, and I will not say his first name to keep it confidential, but his second part of his nickname was the knife. So you know what I mean. So if he would say carcinoma, he would have lost his bladder. I'm just wanting to scare you off. And I'm sure Joan knows who I mean. Okay, we have 60% say yes and 38% said no. Okay, thank you so much for your answers. Well, we were doubting. This was the worst place we could find. And initially, I thought I would call it suspicious for invasion, but because of this nickname of the surgeon, we decided actually to be a bit on the conservative side and say, be conservative, and we called it negative for invasive carcinoma. But the question is, of course, what is the underlying disease? What's going on here? And so the case summary, how we diagnosed it, is as followed. We called it florid cystitis cystica glandularis with intestinal metaplasia. We have shown you. We called it nephrogenic adenoma. We did not consider that as malignant. And we said squamous metaplasia with dysplasia, in fact, carcinoma in situ, and signs of HPV infection, and no evidence for invasive carcinoma. Of course, his clinical history helped in this diagnosis because he was immunosuppressed. The patient had immunosuppression, and so he was more likely to have an HPV or some viral infection. We did actually HPV virotyping in this case, and the patient of the tumor the lesion was positive for subtype 35 and 42, high risk. What happened further with the patient? I think the surgeon, in spite of that, we did not call it invasive carcinoma. He wanted to push for a surgery, for cystectomy. However, the patient himself did not want to depart from his bladder. And this is many, many years ago. And I feel that we made the right diagnosis because up to now, he has no further progression of his disease, no metastatic disease or whatsoever, the last time I checked. So I think we feel vindicated with this diagnosis. Nevertheless, when you see keratinizing, particularly keratinizing squamous metaplasia, you have a differential diagnosis, and it's an important thing to mention in your report whenever you see keratinizing squamous.
Where did you have the settings before?
Verrucous squamous hyperplasia is very rare in the bladder, but that may be also in your differential. A squamous papilloma, so where you have a typical papilloma lined by squamous epithelium, generally it is non-keratinizing actually, which is HPV negative. And then you can have condyloma acuminatum. And this patient had probably first a condyloma acuminatum. Some areas looked like condyloma accumulatum, but there was definitely a carcinoma in situ. The dysplasia was too much, of the atypia was too much, and we called this kind of squamous cell carcinoma in situ, and they can occasionally be HPV positive. There's a very nice overview paper by the group of Epstein in the American Journal of Surgical Pathology in 2006. And well, I think this is the end of this case, case number 1. And but if people have some comments, please come up and please let me know.
I actually, it's a fascinating case, so difficult. I have a question. Is there a known correlation between the other metaplastic changes in the bladder and HPV, like the intestinal metaplasia and all the other background changes?
Yeah, that's a very reasonable question. Well, as you, for the nephrogenic adenoma, I think there is a good reason for this patient to have nephrogenic adenoma because he is a male and he had already previous instrumentation. So previous instrumentation provokes nephrogenic adenoma. So that is not surprising. For the for the cystitis cystica glandularis and the intestinal metaplasia, I'm not so sure. My personal thinking, but I do not have any literature data to back that up, is that there has been chronic inflammation, and that may have also incited or has encouraged this intestinal metaplasia. And I understand the surgeon. I understand why the surgeon was very unhappy because he said there was no way that by cystoscopy he could monitor this bladder. And that's why, and this is a young patient, and having carcinoma in situ for particularly keratinizing squamous metaplasia with or without HPV is already a very risky thing to have. And I understand fully the surgeon. But again, we did not want to pull the trigger on this one, but it was a difficult case. And I think the outcome of the polling actually is in line with that, because we were also kind of, well, what to do? We cut deeper and so on, the usual things you do, but we never could, and I showed it, I'm pretty sure I showed it to my colleagues, and we could not really pull the trigger.
Very difficult case. Thank you.
Well, it's a bit, show the whole thing, educational, yeah.
So if there are, I don't see more questions. I mean, some people mentioned the HPV changes when you said like what's going on. so
Yeah.
they were correct.
Yeah, yeah. Oh, people said so. Yeah, yeah. People sometimes miss that HPV because it's in the wrong location. You think of it in the cervix, of course, but you do not think of it in the bladder. But it can happen in the bladder. So yeah.
Yeah, and yeah, and not everyone, I guess, also has like access to typing, but now it's becoming more prevalent. And someone said, could it be HSV? Like I have never seen HSV. Does HSV happen in the bladder? You know,
I have never heard of it. No. Angiosarcomas, maybe. No, not really.
Yeah,
No,
yeah.
I wouldn't know that. No.
Okay. So if there are no more questions on this case, we can
Then I will stop sharing, eh?
Yeah, sure. And then maybe next case, and then Dr. Kruzova can present the next case. So Dr. Kruzova is my colleague at Unity Health Toronto. She practices at the St. Michael's Hospital site, and she's going to be presenting the next interesting case.
So I just wanted to show you a quick case it's a prostatic tissue. This case came as an acute retention with obstructive uropathy, and the clinical note I just wanted to show you because it shows the tissue looks necrotic and there is a history of radiation. So when you look at the low power of the prostate tissue, I'm not showing you the bladder. So the one thing that kind of caught my eye was all of these red areas, and I thought, wow, that's a lot of blood for prostate. I usually don't see this, but I didn't think anything of it initially. So I zoomed on this area because I thought there was more cellularity, and this is where I show you the high power of what is going on. So when you look, you have quite a lot of atypical cells, prominent nucleoli. There was a lot of mitosis around and a lot of these extravasated red blood cells. So as a pathologist, when I read it and I thought, well, history of radiation, this could be an angiosarcoma. And then I thought, well, I've never seen an angiosarcoma in a prostate, and I don't think I heard of it. So when I did the basic stain, it actually did point out to a vascular lesion. So this is the same image of the one I showed you, and then you have ERK, the nuclear stain, showing positivity. CD31 also positive. When you look at the low power of the H&E image and overlay it with the smaller image with CD31, it nicely kind of highlights the areas where the extravasated blood is, and this is where we have all of those atypical cells. I added. I didn't see anything else in the other portions of the specimen. So what I did, I added additional markers. Just to cover the location. There was a prior history of prostate cancer, so I did the PSA and NKX3, and then since we are around the bladder, I did just P63, and I think I did also GATA at the time, and we looked at it, and this is not a common diagnosis in prostate, so. I sent it very quickly to Mount Sinai Hospital, and Sinai confirmed that this is an angiosarcoma. I made a comment about possibly radiation induced, and so when you look at the literature, this is quite unusual. The one sarcoma that always pops in our head is the rhabdomyosarcoma, usually in kids, young adults. But angiosarcoma, I haven't heard in the prostate. And then when I looked at the literature, it seems like it's very rarely actually the case that you see an angiosarc in prostate. Usually you think of kind of a breast angiosarcoma post radiation, but not really radiation associated prostate angiosarcoma. There were no other risk factors that I saw in a clinical note. Sometimes the angiosarc is associated with lymphedema and arsenic and vinyl chloride. There wasn't anything like that noted in the clinical history, and I don't even know whether that would be kind of sought after by the clinicians at the time of diagnosis. The patient is now should have had a resection recently. Sometimes in May. I didn't see it actually on our system yet last week when I checked. I didn't check now, but the mainstay of treatment is resection with clear margins. There's only a handful of cases in the literature, and patients typically seem to do pretty badly with this diagnosis. If anybody could comment and let me know whether they've seen an angiosarc in prostate or what your experience is, that would be great.
Can I ask a question?
Yeah.
Oh, at first I have never seen one, but maybe I've missed them. I really don't remember them. One question, because I always am a bit of, paranoid. To be paranoid is a very good feature of pathologists. And when a clinician tells me it's a transurethral resection of the prostate, I do not necessarily believe them. It could be from the bladder. Did you see really prostate glandular tissue in the specimen? Because I do not remember, but maybe I missed it when
yeah, I didn't show. Yeah.
So you wonder, is it really from the prostate or is it from the bladder?
Possibly, now I don't remember. I signed in maybe 4 months ago, but I must have done it somewhere because then I added these guys. So that's a good point. Maybe I should just go back because the one was, there were 2 parts of it. And one of them was bladder. I didn't see much in it. Or at least it wasn't malignant. So I don't remember the first part, but the second part was this one. But you know what? Maybe it's a good idea for me to go back to.
The message I want to bring across is never trust a clinician.
I agree. I remember briefly seeing this case with Rihanna, I think before she sent it. It's very ugly, like the vascular component, I think is screaming atypical, like, I don't know, mitotic, whatever. And I don't remember actually if this prostate component or not. That's a good point. Yeah. Yeah. But yeah. It's such a scary case.
I know. Yeah, thank you.
There are a few chats, I think. Okay. So there's a question. Do you know how long ago he had radiation treatment?
The 2012. I think it actually said, or I looked it up because I was interested in it. Yeah, and it's not here, but I looked it up. It's about 10 years ago.
And yeah, there's a question. What was the radiation for? Do you remember the history? Had prostate cancer, right?
The prostate cancer. I looked up some of those. There was one paper I pulled that they did a review of the literature and they found angiosarcoma of prostate in 10 cases altogether, and only 3 of those that had radiation therapy actually had angiosarcoma. So some of them didn't even have RAS. So who knows what the association with the radiation is, whether it's a really association or not. Yeah.
And patient didn't have previous resection. It was like treated, I guess, with radiation at the time. Yeah. Okay. Yeah, I think I remember the history sort of vaguely. Okay. Thank you. No, such a scary case. Thanks. Thanks, Adriana. Thanks. No more questions for this case. Okay, so next would be Dr. Capitano, who also is a practicing pathologist at Unity Health Toronto, the St. Joseph's Hospital site. So Mario, if you're there.
Hey, Rola. Yeah, thanks for the opportunity. I'll share my screen now.
Yeah.
Okay, everyone see the shared screen?
Yes, I can.
Okay, great. So this was an interesting case I had a few years ago. So this 73-year-old male presented to the ER with a 1-year history of recently receiving rectal pain, penile pain, and constipation. He did not have any features of hematuria, dysuria, weight loss, loss of appetite, or any bony pains. On exam, he had mildly edematous suprapubic area and in the genital area. Then on the rectal exam, we had a very large, hard, fixed prostate. So we had a CT abdo-pelvis, then some chest imaging as well, and it showed no lobulated mass in the pelvis, into the focus of the lesion, and multiple liver mets and retroperitoneal and pelvic lymphadenopathy. It did not have any bony metastases. And on the lab testing, his PSA was low at 5. And even though all signs points to this being a prostate malignancy, the urologist was very hung up on a low PSA, and we're entirely convinced it was a prostate malignancy. So since he had a liver mets, they did a liver biopsy first, which showed this lesion here. You have nest of pleomorphic hyperchromatic cells with smudgy chromatin, lots of apoptoses and mitoses, molding nuclei. Here's pankeratin, kind of weakly positive. This is CD56, so extensive positivity. There's also positive for other neuroendocrine markers, synaptophysin, chromogranin. So liver biopsy was diagnosed as small cell carcinoma. And they're really confused, like, they're expecting a conventional prostate adenocarcinoma, but the liver met showed a small cell. So they did a follow-up prostate biopsy urgently, which shows very similar morphology to the liver biopsy. Here you can see nice geographic necrosis, which is typical of a small cell neuroendocrine carcinoma. There's higher power saying this identical morphology to the liver lesion. So I repeated the stains, CD56 positive, pankeratin weakly positive for synaptophysin, chromogranin, TTF1, which is not specific for small cell carcinomas. That's usually positive. Then, so the prostate biopsy is mostly small cell. Then little piece of prostate tissue, so some conventional cribriform prostate adenocarcinoma. Then I confirmed with NKX 3.1 there is prostate. I did a PIN 3 as well, showing no basal cells, and your ricin staining the adenocarcinoma of the prostate. So this was a prostatic adenocarcinoma with small cell carcinoma, and based on the bulk of the lesion being in the prostate, I call this small cell carcinoma, and rising from the prostate adenocarcinoma, urologists are still very confused by the low PSA. So I explained to them that it's mostly small cell. You're not going to have a high PSA when most of your tumor is a small cell. So small cell neuroendocrine carcinomas can be seen at initial diagnosis in 50 to 60% of cases, with the remainder of cases being a mix with your conventional prostate adenocarcinoma. Typically, you see an abrupt transition, and your conventional adenocarcinoma component is usually a higher Gleason score, 8 or higher. If you're still not convinced that this is rising from the prostate, the small cell component can express the TMPRSS2 ERG fusion in about 50% of cases. But I don't think it's necessary when you have the bulk of the tumor in your prostate and no obvious other possible primary sites. So I don't think it's necessary in this case. And regardless, when you have metastatic small cell carcinoma, survival is very low, usually about 7 months with metastatic disease. Yeah, so I found this case very fascinating, especially because the urologists really hung up on the low PSA, but not all prostate malignancies will have an elevated PSA. All right, any questions about this case?
So there's one question, and I actually think it's an very important case to comment on, and I would invite our expert GU pathologists in the panel to comment as well.
Yeah. So in this case, the small cell component was negative for NKX.
Yeah.
Yeah.
Yeah. This is a very special case indeed, because the patient apparently did not have hormone treatment. This is de novo. The patient was not treated for anything yet, isn't it? What we see nowadays more often is the arisal of small cell carcinoma in patients who have been treated for a conventional acinar adenocarcinoma. And then because of this intense hormone therapy, what they get nowadays, that pushes the tumor into a small cell neuroendocrine or a neuroendocrine adenocarcinoma direction. So this is unusual in that this patient was not treated at all. But again, as you mentioned clearly, this is happening. It is not completely impossible. It happens occasionally. I think you worked up the case very nicely. What is quite special, or not special about the case, but what also gives it away almost, is that the patient did not, as you said, he doesn't have bone mets, but only liver mets. I have the feeling that when they get this neuroendocrine carcinoma differentiation, they go much more often to soft tissues like the liver or maybe the brain or the lung or whatsoever. So I think this is a very beautiful case. Sometimes the neuroendocrine carcinoma is not so typical small cell and can be a bit a mix of small and large cell, and sometimes you're really at a loss, and sometimes they do not even necessarily look so much like a neuroendocrine carcinoma. This one really looks like a neuroendocrine carcinoma. And then you really need your markers to show the neuroendocrine differentiation. But yeah, I have no further comments. Thank you.
All right, great. Thanks so much.
Yeah, I thought exactly the same. How come there's no history of androgen deprivation therapy? But I guess it can happen. Yeah. Yeah, interesting case, important case for sure. So next, I would like to present Dr. Susan Prenville to present her case. Dr. Prenville is a GU pathologist at Toronto General Hospital. Dr. Prenville, please go ahead.
Hi, Rola. Thanks. Can you hear me okay?
Yeah, I can. Yeah.
Okay. Can you see my screen okay?
Yes. Yes.
Okay, so thanks, Rola. I will just jump straight into the case. So this was a 31-year-old male who had sort of vague 2-year history of intermittent pain and was initially worked up with a CT scan, which showed a 7-centimeter cystic mass adherent to the dome of the bladder, query urachal cyst. And following that, they did a cystoscopy, which noted a nodular mass at the bladder dome. It looked to be extraluminal, didn't look like there was any mucosal-based lesion or any obvious drainage into the bladder proper. So at the time of the cystoscopy, they decided to take a sample of this mass to try and diagnose it. And obviously, because it was extraluminal and because it was predominantly cystic, we didn't actually get a lot of lesional material. Most of this here was just submucosal tissue with no abnormality, but we did have one fragment which had some findings in it. Looking at that a bit closer, what we had predominantly was just extracellular mucin, lots of pools of mucin that seemed to be dissecting through the tissue. Most of it looked acellular, but we did spot, and I think this wasn't on the initial level, but when we cut in deeper levels, we did spot a little bit of epithelium. And this was basically all that we had. So we had this strip of mucinous epithelium. I think when you look at it, it looks kind of linearly arranged. There is definitely some atypia in it, but although it's within the mucin, it sort of looks like maybe it's been displaced there. I wasn't convinced that it was definitely, invasive carcinoma within a colloid or mucinous adenocarcinoma, but that was all that we had. So kind of putting together the key findings from the clinical, this is located within the dome, clinically a fit with the urachal primary. It was a cystic mass. There was no bladder-based mucosal lesion. And we had dissecting pools of mucin, a strip of atypical mucinous epithelium, and no signet ring cells or anything else that would suggest that we could, definitely call it colloid or mucinous adenocarcinoma. So on the biopsy, we diagnosed it, or we signed it out as consistent with mucinous cystic tumor of urachal origin. We suggested that based on the atypia, it was at least borderline or low malignant potential, but that we'd have to see the whole lesion to definitively classify it and to look for an adenocarcinoma component. And they were, they were happy that this was primary urachal, but obviously, as with all bladder and urachal glandular lesions, it's important to exclude the possibility of spread from another site, particularly GI, which they did do. So they subsequently went ahead and did a partial cystectomy and excised the urachus and umbilicus, and this was the specimen that we got. So we've got our umbilicus up here, and this was the bladder mass or extra bladder mass down here. You can see it was a cystic mass, it was unilocular, and it was filled with thick mucinous contents. And this is just a nice image showing a cross-section of the lesion. So we've got actually our bladder wall or mucosa up here, which looked completely normal. There was no bladder mucosal base lesion. And then the cystic tumor itself is here within the muscular wall. It was entirely cystic, a lot of it lined actually by just a single layer of mucinous epithelium, but then in some areas getting some more complex exophytic components protruding into the lumen of the cyst. Just looking at a little bit of a higher power, as mentioned, we have this, some of it just lined by a sort of single layer of mucinous epithelium, and then getting these more complex areas with papillary architecture, tufting, and so on. But we didn't find any evidence of stromal invasion. All seemed to be confined to the cyst itself. And when you looked at the cyst lining in those more complex areas and higher power, there is some atypia, predominantly columnar, pseudostratified epithelium with sort of moderate atypia, but nothing very severe. So we did sample this extensively. We didn't find an invasive component within it. So our final diagnosis was urachal mucinous cystic tumor of low malignant potential. And I just thought this was an interesting case just to kind of touch on this spectrum of tumors. They are pretty rare, and as a subset of urachal tumors, they're kind of in the minority. But this, I guess, subclassification or way of stratifying them was initially proposed back in 2014 in this paper by Mahul Amin. And it is now what's in the current WHO. I know there's a new or a consensus meeting planned for dealing with urachal and glandular lesions of the bladder for later this year. So I don't know if there'll be any changes to this, but at the moment, we sort of think of these based on this proposed nomenclature from this paper. So they kind of found, and the reason for separating these out, I guess, was that they found that the cystic mucinous lesions did behave much better than the non-cystic adenocarcinomas arising within the urachus, and that there was a spectrum of lesions really going from mucinous cyst adenoma, which is basically benign, to mucinous cyst adenocarcinoma, with these lesions in between, which they termed mucinous cystic neoplasm of low malignant potential. And the classification is sort of analogous to that of similar tumors arising within the ovary. So the majority actually within this category of tumors are the mucinous cystic neoplasm of low malignant potential. And just to show you some images of that spectrum that we see histologically, so mucinous cyst adenoma should be lined just by a single layer of bland mucinous epithelium, whereas when we get what we had in our case, you start to get more complex areas, more architectural complexity with papillary formations, tufting, and so on, as well as some cytologic atypia, usually sort of on the moderate end. You can sometimes get more severe atypia and areas of cribriforming, forming, which you can term intraepithelial carcinoma, but still confined to the lining of the cystic tumor. And then obviously when you've got invasion, it's termed cyst adenocarcinoma. And in that paper, they did also subclassify those into cases with very limited invasion or microinvasion based on less than 2 millimeters or less than 5% of the tumor, as compared to those with more overt invasion. And they did find that even the ones with pretty limited invasion still tended to behave quite well. Of course, a caveat being that these are very rare and there's not that many cases. And even in their series, they didn't have follow-up for all of them. So just practical considerations, if you get a case like this, I guess number one is that they should be sampled extensively if you're dealing with the mucinous cyst adenoma or low malignant potential category, because you can find invasion and it can be quite focal within the wall of the cyst. And the other thing, and I've seen this in other cases, that they can have quite a lot of degenerative changes, because often they've probably been there for a very long time. You know, they don't cause symptoms initially, they're cystic. So they can get a lot of mucin extravasation, which we saw in the original biopsy of this case, fibrosis and calcification. It can look quite distorted. So I wouldn't, you know, call invasion unless you've got definite invasion. Just acellular mucin pools on their own wouldn't be enough. So that is end of my case. And I'm happy to take any questions or comments. Stop sharing.
That's a very nice case. Urachal tumors are very rare, and these, I suppose, are even rarer. So I have a question, like, so the patient's cured now. How clinically, how are they deciding to follow up the patient?
Yeah, so this patient had their surgery, I think, about a year ago, and their last follow-up, they did do imaging and everything is fine. So most likely, I mean, he's a very young patient, so I don't know what their long-term plan is with respect to how frequently they're going to image. Like, probably they're going to image him more frequently the first 5 years and then taper off after that. But certainly with limited follow-up so far in this patient, he's all clear and hopefully will remain so.
A very interesting case. Thank you. I mean, it's also very it's good that they did biopsy it beforehand. I suppose in that case, they still did a partial resection, because I had a case where clinicians were very suspicious of a urachal carcinoma, did a cytology, and eventually went ahead for the partial cystectomy, and it was not cancer at all. It was all inflammation, xanthogranulomatoous inflammation. I don't know if they would have treated the patient differently if they knew it wasn't cancer. Maybe they would have thought it was non-diagnostic, but it's interesting also how correlative the biopsy was with the final diagnosis.
Yeah. I mean, initially, I have to say, when I looked at the biopsy, I was like, oh, like, because they described a 7-centimeter mass. Like, we don't really have anything much here. But then when, you know, we did have the mucin, we're definitely kind of in something neoplastic, and we found a little bit of epithelium. So yeah, I'm not sure, like, if they would have, irrespective of the biopsy, whether they would have gone for surgery anyway. I'm not entirely sure, but as you say, obviously there's a risk then that could be something just inflammatory. But he's, I guess, a young man, and it wasn't resolving. They may have done surgery anyway, but yeah, we were happy we found something on the biopsy.
Sometimes I wonder always, sometimes it can be difficult to distinguish whether it is an adenocarcinoma related to urachal or whether it is primary from the bladder mucosa. So did the patient, did they say something on the cystoscopy that the mucosa, the bladder mucosa was completely normal, or did they take biopsy from there?
Yeah. So the cystoscopy was, they described a nodular mass at the dome, but it was submucosal. So they did describe that there was no bladder mucosal based lesion, which was very helpful, because they thought it was coming from the urachus, and the imaging as well. They were quite happy that it was urachal in origin. So yeah, that's helpful. Yeah,
this was a beautiful case, actually. Yeah, very good. Yeah, sometimes you get transurethral resections where they go through the mucosa into that mucosa, because it's probably not such, or the distance from the urachal mass is rather close to the surface or something, and then you can be stuck as a pathologist because you do not know for sure whether it is really urachal origin or whether it is a bladder origin adenocarcinoma. And then people say always you have to look at whether there's intestinal metaplasia or something like that in the pre-existing bladder. I'm not so sure whether that is really very helpful, but maybe that's why the consensus conference is going to be very helpful for that also. Thank you. Yeah.
Thank you very much for the case. So next would be, so Dr. van der Kwast, your second case.
This was a case which caused me a lot of trouble, I must admit. This was a female of 75 years, and there was already a history of bladder cancer, but actually low-grade bladder cancer, if I remember correctly. And now she came back with a recurrence of her bladder cancer, or in any case, with a recurrence, a tumor recurrence, I can better say. So the patient had already been under the surveillance of a urologist, and they biopsied lesions in the area of the bladder neck. That's basically what we got. And this is a low power view of this lesion. What we see is quite a solid area, actually, quite almost demarcated area. There were no papillary structures. It was quite cellular. You can see it's very purple. And there was also some necrosis in that area, some necrotic area. So that just gives the overview, gives you a bit of background of this patient. And when we look further in this cellular mass, we appreciate that actually there are some large cells in this mass. You can see, if you look carefully, you see kind of multinucleate cells, multinucleate giant cells, and a lot of smaller cells. And again, it's quite a cellular mass, essentially. That's what you see. At this power, you cannot see. So here at higher power, we see that these giant cells in this mass have a rather typical morphology. The nuclei, it is not a typical feature of an Langerhans cells or something like that. And in addition to these large cells, these multinucleate cells, there's also a population of smaller cells which are there. These are really small, look rather bland actually. They do not show very much atypia. And well, that's basically what you see here. And here another higher magnification, just to get you a better impression. There's maybe some necrosis or some hemorrhage or whatsoever. I think it's falling apart kind of thing. And here again, all these giant cells, and then some kind of smaller cell population, which has rather prominent nucleoli. However, if you look more carefully, you see some mitotic figures, like here. Here you see a mitotic figures. And there are a few more mitotic figures somewhere. I don't know exactly where, but I think maybe this is a mitotic figure. I'm not so sure. But this one definitely is a mitotic figure. So you have a bit of combination of features here. And the question is, there was also an area where it was a little bit more spindly, spindle cells, and also with a few mitotic figures here and there. So this is basically what we saw. The question is again, I think we are going to a poll again now. Oh yeah, we did, of course, we did immunostain, because before you do an immunostain, of course, you start thinking, what could it be? And it was a bit like, well, it could be a reactive process. It didn't look really like an ordinary urothelial carcinoma. And yes, the CD68 decorates the giant cells, but also the surrounding cells. There's a lot of CD68 positivity, as you can see in this picture. You probably all would agree with me that this is really very positive. And then we did, of course, also a CAM52 staining. And we see, that was a little bit disturbing, actually. We see, but not that much, but there is some patchy CAM52 staining in this case. And I think now we come to the poll, and we are going to ask you, is this going to be a malignant or a reactive process, and how to distinguish? I'm always very good in throwing red herrings in. That changes the, I bias you, huh? How many people we have? We have 32 people participating. I think we have, yes, malignant 34%, so 1/3. It's pretty nice, actually. And 2/3 said no, it is not malignant, it's benign. And actually, and I have to admit that I also, after at least kind of 35 years of practice, I make mistakes. So I made a report and I said benign, reactive. However, I looked again and I looked again. You know, you have those cases where you cannot get to sleep actually the next day. And then I said, okay, there is something weird with this. And of course, I should share my results. So this is the sharing, these are the results of it. So most people would agree with me, but there is a 1/3, that's a considerable number of people think it's malignant. And actually it's a matter of knowledge, awareness of very strange variants of bladder cancer which can happen. And this is because then I did the next day, probably I did a MIP1 staining. And this is wow. This is really wow. I mean, a reactive process and a MIP1 like that, well, that is really problematic. And then I did a GATA3 staining. And the GATA3 stain shows most cells are very intense positive, no doubt about it. And I do not think macrophages would show such a GATA3 positivity. And the giant cells, actually, these osteoclast-like giant cells are GATA3 negative. So then I changed quickly my mind and I submitted a revised report. I amended my report, an amended diagnosis. And the diagnosis is, and maybe someone knows I won't go ahead. There is a rare entity, it's really uncommon, which is called osteoclast-rich undifferentiated carcinoma. And you really must know about its existence, otherwise you might go wrong. And what is the most problematic part of this diagnosis is that they can be almost entirely keratin negative and can be totally CD68 positive, like this case. And because the immunostain actually puts me completely in the wrong direction, and probably other people would be also put in the wrong direction. So this is the thing. The key differential diagnosis, for urothelial carcinomas with giant cells would be with cytotrophoblastic differentiation. So these have multinuclear giant cells, but the nuclei are hyperchromatic, and these giant cells are part of the neoplastic process, and they would be GATA3 positive, I would think, and also keratin positive. So this is one of the possibilities, but because the giant cells looked really like Teutons, like osteoclast-like giant cells, that is really different. Another thing, and I was thinking that was the case, that this would be a xanthogranulomatous inflammation, which is reactive. And xanthogranulomatous inflammation, that's characterized by presence of giant cells, but they do not have that osteoclast-like giant cell morphology, and they're against the background of histiocyte lacking atypia, and I suppose the mitotic activity in this xanthogranulomatous inflammation is not common. You can see occasionally xanthogranulomatous inflammation against the backdrop of a regular conventional urothelial carcinoma, even in low-grade urothelial carcinomas. So that is something you have to keep in mind as well. So key references, there are a number of publications, and also on urinary bladder xanthoma, which is also a differential, but this one had more the giant cells, and particularly this paper, again by the group of Epstein, an expanded immunohistochemical profile of osteoclast-rich undifferentiated carcinoma of urinary tract, which is a very helpful paper to appreciate this rare entity. So the tumor had a solid and cellular appearance, including multinucleate osteoclast-like giant cells and smaller ovoid cells, assuming sometimes a spindle-shaped and whorled morphology. I would not have called it a sarcomatoid carcinoma. It was not really areas of sarcoma morphology, so that was not really my thinking. CD68 is positive for both the osteoclast-like giant cells and also the smaller cells. And the patchy pancytokeratin staining can be seen, including some part of the smaller cell population and excluding the osteoclast-like giant cells. GATA3 again shows the morphology of cells is positive, but excludes again these osteoclast-like giant cells. P63 is also negative in this case. So again, this is and the prognosis of this variant of urothelial carcinoma is poor. This is a very unfavorable prognosis. So it's an important diagnosis to make. Any comments, questions?
It's quite a pitfall case. It's actually very scary. Is it treated?
Moi, je le fais.
There's a background. Someone.
What is the background? Yeah.
You can, yeah. Okay. So there's a comment that said, "Looked like a giant cell tumor of soft tissue, but the location is odd with mitotic and the mitotic activity is suspicious." It does actually look like a giant cell tumor. There is like sometimes I find it's confusing for clinicians to convey all the variants. So first part of my question is this variant is recognized as a bit more aggressive in the WHO, is it? Or is it treated? Yeah.
This is much more aggressive. Yes, yeah, that is very aggressive. Yeah, yeah. I don't know. Sometimes I put in this situation, I would put in a comment in my diagnosis part and putting a reference and explaining to the clinician that this is a serious matter. I had to do anyway because I amended from a reactive process to a really malignant process, which is quite a big step. Fortunately, I came to know just a couple of days later, so it was not really. I don't think it was a big deal, but it was important to realize. Yeah.
and then the spectrum of the stuff, like I had a discussion before with clinicians where I had to explain all the giant cell variants that exist. So, and then there's the urothelium with sensation trophoblasts, and then there's a giant cell variant, which is also aggressive, but like different, I guess. Yeah, but it can be confusing, I think, sometimes for the pathologists even to
I think
call all the variants.
I think that the most, although I think all these kind of what you call it, these cytotrophoblasts, like which are very rare actually, are behaving probably as bad as this one. But I think the main reason why this entity, this variant has been described is to recognize it as a pathologist, because you easily would overlook it. As in any case, I did initially, and so you need to know about its existence, and
Yeah, very nice, very important case. Thank you very much. Thanks.
Yeah.
I'll
stop sharing now.
Yeah, sure. There are no more comments. I will move on to the next case. So I would next like to present Dr. Sarah Morgan, who practices at Markham Stouffville, and Dr. Morgan would be presenting a very interesting case. I had heard about it briefly, and I thought it was really fascinating and important to present. Thank you.
So I'm going to present a case that I came across last year, and I'll tell you an update about the patient. So we had a patient who presented to Markham Stouffville Hospital. He's a 74-year-old male patient with shortness of breath and overall previously healthy. Investigation showed COVID-positive pneumonia, but he also presented with an acute kidney injury and cytopenias on the peripheral blood. The peripheral blood also showed evidence of hemolysis, and the patient had an M band, which was IgM kappa. Due to the acute kidney injury, they went ahead and did some imaging. So the ultrasound and confirmed by CT abdomen and pelvis showed a mass that was 3.9 centimeters with vascularity at the left uretrovesical junction and splenomegaly. This is the picture from the CT abdomen, and it shows this mass in the bladder that was newly diagnosed in this patient, not known before. So the patient actually did have a DAT-negative hemolytic anemia. He had an MGUS, which is monoclonal gammopathy of undetermined significance, and he was scheduled to have a bone marrow aspirate and a transurethral resection to diagnose his bladder tumor. So here we see pictures of the bladder tumor. It looks papillary in architecture. And here is another view as well, which shows multiple layers of the urothelium. On higher magnification, we do see that there is significant pleomorphism, hyperchromatic nuclei, and mitotic figures. Here's another view as well, showing more mitotic figures. So we realize we're dealing with a high-grade papillary urothelial carcinoma. And we looked, so the mass was quite big. It was submitted in 4 blocks, and we were trying to see if there is any lymphovascular invasion or if it's muscle invasive or not. So some of the fragments did show that the urothelial carcinoma was non-invasive and the lamina propria was clear. But on other sections, we could see here, as shown by the arrows, that there were some cells that were quite circumscribed and in the lamina propria, and we were not sure what those cells represent. Another view is showing that those cells within the lamina propria are rounded, discohesive. They still have also some nuclear pleomorphism, and they look atypical. Another block as well is showing the same finding in the lamina propria, and we were guessing, is this an invasion to the lamina propria, or is it something else? So more views at higher magnification showing those in all the blocks that we had. On high power, still we see some mitotic figures, apoptotic bodies, and high nucleus cytoplasmic ratio. And in comparison to the urothelium that's adjacent to it, we can see that the cells are slightly different. So those in the lamina propria do not have the same eosinophilic cytoplasm. They seem to have higher NC ratio and scant cytoplasm, and they look slightly different morphologically. Here's another view as well, confirming mitotic figures as well. And this is a 40x magnification. We had muscularis propria in our sections, and it seems that those cells as well, seen on the left side of the screen, were very close to the muscle, and we were not sure, is this a muscle invasion or not, although it was not going through the muscle fibers, but quite there. Another view as well of those atypical cells, very close to the muscle fibers. So I have a poll question. What would the audience think about those atypical cells in the lamina propria? Do you think those represent an invasive urothelial carcinoma, a hematolymphoid process, lymphovascular invasion, or something else like detached cells or artifactual? Okay, that's a great answer. So yes, so like 10% or less than 10% are thinking it's an invasive urothelial carcinoma or a lymphovascular invasion, but the majority are thinking this could be a hematolymphoid process. And that's a great answer. I'll take you through the other slides and through the immunostains that we performed on this case. So we did a keratin stain that was negative in those cells in the lamina propria. And we did also GATA3, which is nicely highlighting the urothelial cells, but it's negative on those cells in the lamina propria. A pan-ERG staining is showing nicely the vessels that are highlighted by the ERG stain. So this process is actually intravascular, as we were suspecting on H&E, but the keratin is negative, proving that this is not an epithelial tumor. So this case was signed out as a high-grade papillary urothelial carcinoma with no definitive features of invasion, and LVI is negative and was pending further workup. So this case was presented at our consensus rounds, and we are a big group of people with different subspecialties or different areas of expertise. So I suggested what if we do CD20 on those atypical cells, and it was nicely showing that all those cells are CD20 positive, as we were expecting on morphology, and as most of you were expecting as well. So I looked back, so I took the case from my colleague. This case was my colleague's case, but when it was a lymphoma case, I took over and I looked into the history, and the patient had a bone marrow biopsy done 1 month earlier to the bladder resection. And the bone marrow did show an 80% involvement by a lymphoid process that's shown here on the screen. And on the workup that my other colleague did, it was a B-cell lymphoma, but it was an indolent type of lymphoma. It was a lymphoplasmacytic lymphoma, which was kappa restricted, and this was also proved by molecular markers. So I went to the TURBT and did more staining to see if I'm dealing with the same process or not, although they looked morphologically different. So despite being kappa restricted, just like the indolent process, this lymphoma was CD5 positive, and this was not the case for the indolent process. And the Ki67 was quite high. It was approaching 100%. So this was lending support that we're dealing with a high-grade lymphoma, not an indolent lymphoma. So this case was signed out as large B-cell lymphoma favoring intravascular B-cell lymphoma. And further staging did not show any other organs of involvement, and the splenomegaly was probably due to the hemolytic anemia and the other indolent lymphoma. There were no masses, no lymphadenopathy, and nothing to suggest other sites of involvement. So the patient went ahead and had the typical treatment for large B-cell lymphoma, which are 6 cycles of R-CHOP, and he was doing well. But recently, when I was preparing this case to present it, unfortunately, the patient, I found that he passed away because of progression of his lymphoma and CNS involvement. So he was not doing well, although initially there was a good response. So I just want to highlight quickly on an intravascular B-cell lymphoma. It's an aggressive lymphoma. that exclusively has proliferation of B cells in the vascular spaces with sparing of lymph nodes and with no other organ involvement. And that's why it has a bad prognosis or aggressive features, because it's often delayed in diagnosis due to the late presentation of the patient. And the screen here is showing that virtually every organ can be involved, like lung, adrenals, skin, alveoli, although it has a certain predilection for CNS and skin involvement. So the patients don't do quite well. It's aggressive, and I'm just throwing some highlights on this because we often see lymphoproliferative disorders in prostate biopsies, kidney biopsies, bladder specimens. So just if you think there is something that's off or not going well through CD20, it could be a lymphoma. Thank you.
Beautiful case.
Yeah. And very scary. I wonder would I have missed it or not.
Well, you would have been wondering when you see all these small nests that's why in that bladder. It's really a crazy situation that you have a bladder to find out this diagnosis. But when you see all these small nests, I was almost thinking, could it be a nested variant? But it was a bit odd, of course, because it stopped at the muscularis, so it was kind of linear. So it was a really crazy case. So all these nests were all surrounded by endothelial cells, I must expect. That's what I suppose. Is that
yes,
correct?
yes. We did Pankey-Erg on several blocks, and it was confined within the vascular spaces, not going beyond.
I must say the immuno is really helpful here. Thank you.
Yeah. Thank you.
There is a question. There's a question. Did the patient have a renal biopsy also?
I don't think the patient had a renal biopsy because all what was there on the CT scan was a back pressure from the obstructive uropathy and hydronephrosis. There was no mass to suggest further investigation.
Thank you very much, Sarah, for the case.
Thank you.
Okay, so and then next I will be presenting a case. And I do practice at Unity Health Toronto and at the St. Michael's Hospital site, and I'm going to be presenting a kidney biopsy case. So this case is a 30-year-old male. He presented with hematuria for a few months and severe weight loss of a 30-40 pound weight loss. So he really wasn't doing well. CT showed an upper renal pole mass, the right kidney, that was approximately 4 centimeters, but looked like it could be infiltrating into the kidney sinus fat. And also CT showed adenopathy, multiple lymph nodes, retroperitoneal, mediastinal, as well as lung masses. So it seems like a widespread disease. And then next step was to do a renal biopsy of the mass. And this was the mass. I didn't prepare a poll, but I would be asking for differential soon, maybe in the chat, please. So on low power, this is renal parenchyma, and there is a mass on both ends, which is not usual. Like usually when we see renal cell carcinoma, we see it on one side and then normal kidney on the other side. And I'm showing this for a specific reason. Again, this is the interface between this high-grade lesion and the renal parenchyma, and it seems like it's infiltrating. It's not quite well delineated from the renal parenchyma. And the reason I'm showing this is that there is a very specific differential for cases that are high-grade infiltrative in the kidney, like this one. So again, renal interface, and you can see the mass itself is like the lesion itself is like solid, cribriform, sort of an adenocarcinoma that's infiltrated into the renal parenchyma, not quite delineated or circumscribed. Cribriform, an adenocarcinoma, high-grade adenocarcinoma picture, and more adenocarcinoma, a bit of a mucinous look to it. Areas that are quite solid and high-grade. And I bet you're thinking, okay, I would like to ask the audience to say if there is a particular differential to this. What's your differential? I would like to know what you're thinking. Okay, met versus primary. Any other thoughts? collecting duct medullary. Very nice. Exactly. What else? If primary, like what other primaries maybe? Any other ideas? Urothelial. Yeah, urothelial. Exactly. I think I heard what I what I wanted to hear. Urothelial adenocarcinoma. That's right. Yes. If urothelial, it would be yes. It would be urothelial with glandular differentiation. Agree. I agree completely with that differential. So exactly. So the differential diagnosis of a high-grade infiltrative carcinoma or an adenocarcinoma of the kidney is exactly that. It's primary versus a metastasis. Metastasis, of course, could be anything. It could be lung, it could be colon. In this case, patient's quite young, which gives us pause. Could it be something hereditary? But if primary, it definitely can be urothelial carcinoma, urothelial with glandular differentiation, or one of the very high grades carcinomas of renal cell origin, which would be a collecting duct, a medullary, two relatively newer entities, FH deficient RCC, because it's high grade and can present like anything. And there's an alk-rearranged RCC, which is quite rare, but can present as a mucinous form of an adenocarcinoma. So it's also sort of worth considering. But top two, if it's something of renal cell origin, would be collecting duct and medullary renal cell carcinoma, which is now a molecular defined entity. And I'm going to be speaking more about it. So SMARC B1 deficient medullary renal carcinoma. So excluding urothelial, this is GATA3, also did P63, and it's negative, quite negative. And these are the renal tubules. It just shows how infiltrative the lesion is in the renal parenchyma. So negative GATA3 and positive PAX8 and metastatic markers like CDX2, TTF1 were negative. So it's a PAX8 positive. So going back to that differential, it would be something within this entity, a carcinoma of renal cell origin. So collecting duct, medullary, FH deficient, or ALK rearranged. High molecular weight is positive. It's not quite specific, but often collecting duct and medullary can be positive for high molecular weight. Distal nephron origin marker. FH was retained, so it didn't look like it was an FH. And it doesn't quite look like a morphology too of an FH deficient renal cell carcinoma. CK7, again, not specific, but it was like, it could be, I guess, patchy in any of these cases. It was patchy in this case. Yeah, I gave it away too soon. So an ALK was negative. So I was convinced, like based on the fact that FH was retained and ALK was negative, and ALK is a very rare, ALK rearranged renal cell carcinoma is a very rare entity anyway, that it should be one of the other two, the medullary or the collecting duct. And collecting duct is really a diagnosis of exclusion. So like I had to hunt down a medullary first, and then if it's not that, then it would be a collecting duct. So to diagnose a medullary renal cell carcinoma, I had to do an INI or a SMARC B1 stain, and we don't have it in-house in our institution. I do it to Sinai. I send an unstained to Sinai for these cases. But first, there is one marker that could be helpful that is positive in like 50% of the medullary RCCs, which is OCT4. So this case was positive for OCT4. So I signed it out as favor medullary, pending the SMARC B1 stain. I didn't have a history. I tried to hunt down for a history at the time of for sickle cell trait. I couldn't find it. Maybe I didn't look.
Did you see accumulations of polymorphs?
Polymorphs, no. I couldn't really make the diagnosis of a sickle cells on the blood vessels. I showed it to one of our heme pathologists, and he wasn't comfortable making the diagnosis. But I didn't see polymorphs, no, not on the biopsy. But I did send it for SMARC B1, and it is negative. And you can see internal control, the renal tubules and the stroma are positive, and the tumor is quite negative. So in retrospect, I hunted more actually for sickle cell trait, but this is the panel. So PAX8 positive, high molecular weight positive, CT7, FH was retained, OCT4 positive, metastatic markers are negative. P63. I even considered like an adult Wilms component, even though it didn't quite look like that, but I did a WT1 and SMARC-B1 was lost. So I hunted more for medical records in retrospect, and I did find all records that did indicate the patient had sickle cell trait. So it's widely metastatic disease. This was diagnosed, I believe, like a month ago or a month and a half ago, and since then, patient has progressed even worse. Is really doing very poorly. So SMARC-B1 and I1 deficient renal medullary carcinoma now is considered a molecular defined entity. If we don't have the SMARC-B1, we wouldn't call it medullary, or it would be maybe a default collecting duct, or it would be an RCC with medullary features, medullary renal carcinoma features, but it wouldn't be quite called that definitive entity. In the WHO, essential for diagnosis is a high-grade infiltrating adenocarcinoma that's SMARC-B1 deficient. Desirable is to have some indication of a sickle cell disease or a sickle cell trait. SMARC-B1 gene is inactivated or lost in these cases on both alleles. It's often either translocated in both alleles or deleted in one allele and translocated in the other allele, but that is thought to be the primary gene deriving this cancer. You can have SMARC-B1 loss in other renal cell carcinoma, and it does not constitute a medullary renal cell carcinoma. So you have to have it in the right context. It has to be in this context of a high-grade infiltrating adenocarcinoma that is thought to be driven by the SMARC-B1, because you can have the occasional high-grade clear cell or translocation, or there are reports like that of high-grade renal cell carcinomas or sarcomatoid renal cell carcinomas that have SMARC-B1 deficient, and it's thought to be secondary, not primary in this case. And the prognosis is really bad, like 90% of the patients present with metastasis, and overall survival is like 8 months. Yeah, so stop sharing, and I would appreciate any questions or comments on this case. This is it for my case. And next we seem to be ahead of time today. So last case would be presented by Dr. van der Kwast. Dr. van der Kwast's last case today.
This was the last case, you hear me? This is what I would call a Friday afternoon pitfall. This is really a dangerous case. I remember when I heard about it the first time, I thought, oh my gosh, how often have I missed this? This is a bit rather typical story, male of 50 years. And he had trouble with peeing apparently, voiding dysfunction, initially improving after antibiotics, but it recurred. He kept having this voiding dysfunction, whatever that may be. They did an ultrasound at the time and they saw a lesion at the dome of the bladder, and the transurethral resection was performed. And this is a nice image, a low power image of the tumor. It's very cellular. And there's hardly any mucosa to be seen. I don't think I see any mucosa. There is some muscle here, and this is a very, purple, very cellular process here, what you can see. And this is the morphology at a little bit higher power, strands of cells with an epithelial morphology. And it clearly seems, I would say there's no doubt, it's kind of infiltrating pattern, quite extensive infiltrative pattern. And another picture here, another area. And you see clearly that there's some stroma around it, but in other areas you see really it's in the muscle. So the poll is again on malignant or benign. I think there's an overwhelming majority calling it malignant. So about 10% says benign. So I share the results. I stop. Here we see the results of the poll. And yeah, that's why I call this. This is a Friday afternoon scare. So you want to go home quick and you think, oh, I do this last transurethral resection. You look at it and you see this. It's a bit distorted, I must admit, which be careful there. But we see clearly invasion in the muscle. This is detrusor muscle. These are big bundles of detrusor muscle. And this is infiltrating detrusor muscle. So you sign it out as a T2 high-grade urothelial carcinoma. carcinoma. Next patient, please. You go home. Now we look at higher power in the better preserved areas. And when we look at higher power, we notice something a bit unfamiliar, I would say. The nuclei are vesicular, but nicely blend actually, and very nice round contours, smooth contours. We do not see really mitotic activity here, and nucleoli are not very prominent. And the cytoplasm is rather basophilic, I would say, and a bit granular. And you start thinking, hey, what the heck? And here another example of another area of the same tumor. Again, this granular kind of basophilic granular cytoplasm, and the rather blend nuclei. That should give you a little bit pause on when you try to diagnose this case. This looks a bit unusual for an invasive urothelial carcinoma. Of course, you have large nested variant urothelial carcinoma. They look very blend, but they look more eosinophilic. The cytoplasm much more eosinophilic. They have much more cytoplasm. It looks different from this. Here in this situation, you would never think of a large nested variant of urothelial carcinoma. So the question is, what is it? And we did the chromogranin A, and now everyone thinks, oh, wow. And well, for some unknown reason, our endocrine pathologist always likes us to do a tyrosine hydroxylase, and it is very positive. So our diagnosis was a paraganglioma involving the bladder wall. And well, whether it's malignant or not, I think 90% of them are benign and 10% are malignant. So everyone was correct, actually, but you cannot sign it out as a T2 bladder cancer, obviously. The pitfall is that you would think of a paraganglioma that these tumor cells are arranged in nests, nice nests. But I have the impression that in the bladder, when they grow in the bladder, they're not so nicely nested as they are in other places. And you often miss the kind of cells, the stellate cells around them. You don't see that very clearly. And once you have this diagnosis of paraganglioma, you need to work up the case. You need to do a little bit additional work up because you have to look at the expression of succinyl dehydratase, expression of that, the subset of number B, how you call it, the B variant. If that's subset, how do you call it? It has a kind of name, but anyway, the CDHB set is missing. It could be that it could be missing because the SDHB is deficient, but also any of the other components of this complex could have an alteration, a genetic alteration. And SDHB staining is a very good staining to show the absence, to show if there is an alteration in this SDH gene. So this is a typical example. If the SDHB is intact, you see a kind of cytoplasmic granular staining, and all cells, including the tumor cells, are positive, no lack of granular positive. And this is an example where there is a loss of SDHB staining, and these patients have apparently an SDH mutation. In this case, the patient had a mutation in the C subunit. Subunits, that was the word I was looking for. Thank you. Anyway, you can do this kind of staining. So the diagnosis was a paraganglioma, and the giveaway is very often, if you have a good transurethral resection, is that you have an uninvolved mucosa and lamina propria, and the tumor is really far away from the mucosa. So once you have a transurethral resection where the tumor process is away from the mucosa, you have always to be very cautious. If you do not see a contiguity between the urothelial mucosa and the tumor, you have to think either it's a metastatic lesion or it is something like a paraganglioma, like in this case. So about 30% of the pheochromocytomas and paragangliomas are associated with these germline DNA alterations like red VHL, neurofibromatosis, and succinate dehydrogenase. And they can be then hereditary. It's an hereditary thing, and then people need to have genetic counseling. And about 15% of the pheochromocytomas and paragangliomas are associated with these SDH mutations. So that's why immunostaining for SDHB is very helpful in triaging for genetic testing. Again, this can be a big pitfall. You might mistakenly think it is an invasive high-grade urothelial carcinoma, but it isn't. And this has a very different prognosis, and very often a partial cystectomy would do the trick, and then patients will be followed by the clinician. I think this is the last case, and I would like to have your comments.
Very nice case. There is a question, I suppose, in a comment about paragangliomas. The comment is, are they always malignant until proven otherwise?
I think is this not a series of tumors where you have this kind of 10% rule, and 90% is benign and 10% is malignant or something like that. So you also have to wonder whether it could be metastatic from a malignant paraganglioma elsewhere, and you can only say that it is malignant when it is metastasized. And what helps to distinguish, that was I was told by Oscar Metti, whether to distinguish between primary or metastatic is to do the S100 stain, because when they are metastatic, they would generally lack the S100 positive stellate cells, and if they are primary, they still retain these stellate cells, these cells surrounding these nests of paraganglioma cells. So I'm told that would be the trick. Of course, you do a lot of imaging or whatsoever, and I think they do kind of somatostatin imaging or something like that, and they will pick up whether the patient has multiple foci, which can be multiple primary, because in the syndrome you have, of course, multiple primary, but you can have the situation in a less frequently that it is metastatic. Yeah.
A good pointer is, like, I'm always, when I get like one of these endocrines, like either a adrenal adenoma or a paraganglioma or a bladder paraganglioma, I always look up, like, when do I need to report? Because I don't see them that often. Like, is it mitosis? Is it necrosis? Do I call it benign? Do I call it malignant? It's always like very confusing from that aspect. Yeah.
What I forgot to mention is, but I think that's very relevant, if you worry about whether it is invasive high-grade urothelial carcinoma or paraganglioma, and you decide to perform a GATA3, you have a problem, because paragangliomas are positive for GATA3, as are high-grade urothelial carcinomas mostly. So the GATA3 might in fact not help you and put you on the wrong footing. So be careful with GATA3. Paragangliomas are positive for GATA3. I forgot to mention that. I think that's very important for the audience to realize.
Yeah, thanks. Yeah, good pointer with the S100.
Of course, if you think of it, the chromogranin A and the synaptophysin or whatever would help you a lot, of course.
Yeah. It would be keratin negative, correct? Like the paraganglioma. Yeah. Okay. So, nice case. Thank you. There are a bunch of very interesting possible pitfall cases. I think that's was the theme of today, like all potential pitfalls.
Quite
very
special
informative.
cases, I must say. I was impressed. Yeah. Very good.
Yeah. No, so they're very nice mix of cases.
But I hope it's not going to confuse the audience, and I hope they understand the background lessons, that there is some kind of awareness of that this can happen, but it should not confuse people, of course. Yeah.
No, and I think in most cases, just thinking about it and doing an extra stain or two, like, led to the right direction. It's just like having that in the back of your mind, I guess, when you're looking at the cases. This is the message here. Yeah. Very nice cases. I don't know. I appreciate any more comments from the audience, but.
I must say the audience is very quiet, actually. They're very timid, or what is happening?
Yeah.
Okay.
Yeah, it was, and we had, anyway, it's the really nice mix of cases. Thank you for the audience. Thank you for the presenters very much. And thank you very much, Dr. van der Kwast, for being the guest speaker today and for the valuable knowledge and information. And I believe there's going to be an email sent for the survey and the CPD points. And thank you all very, very much for attending today. Thank you.
Thank you.
Thanks.
Yeah, thank you
Thanks.
for having me. Yeah.
Everyone. Thanks.
Bye.